coefficient. So in that case, you can actually take that away. So your effluent flow rate will be your determinant of your clearance. So if urea concentration is 30, is 100 in the blood, it's going to be a 30 or 100 in your effluent. So that give you one, which is your effluent concentration divided by blood concentration. So your clearance equals your effluent rate. Next, please. So when you see those small molecules, sodium, phosphorus, potassium, all of these are very small. They are below 5,000 Dalton. So all these are quickly can be removed. When you get to metal molecules, 5 to 1,000 to 50,000, these are the ones that you need more convective clearance to be able to get rid of. And for albumin, that's something you don't want to get rid of. That's the large molecule that doesn't go through. Next, please. So effluent flow rate is your, it depends on what kind of modality you use. So it's your replacement fluid, it's your ultrafiltrate plus your replacement fluid if you were using CVH, it's your dialysate, it's your replacement fluid and dialysate plus the ultrafiltrate if you use CVHDF. So it's the ultrafiltrate plus what kind of fluid you're using. If you're using replacement fluid, if you're using dialysate, plus your ultrafiltrate. Next, please. So when we say a dose, we take that effluent rate and divide that by kilograms, so it gives you ml per kilogram per hour. If you want the urea clearance, then your effluent rate, which is ml per hour, you divide that by 60 minutes, that give you ml per minute. And that should apply to small clearance molecules. Okay, next please. So let's try this. I want you guys to start going through this one at a time. So let's start with, I want you to unmute yourself, fellows. Let's start with Qasim. What do you think the first one?
Hi. So here, CVHT is highly better than
in potassium removal. So I want everyone to take one at a time.
Oh, sorry. So this is a true or false question. Okay. Oh, got it. Okay. So CVHT is highly better than CVH in potassium removal. So essentially, so that would that may be true.
So
I think because sorry.
So what is it? So this is we're talking about dialysis versus convection. So
Yeah.
convective clearance versus dialysis clearance. Is there any difference in the low molecules, small molecules?
Not much difference.
No much difference. So that's wrong.
Okay.
So there's no big of a difference. Okay. Then let's go to next one. And let's go in that order. Zaid. Molecular weight is the main factor for drug removal by CRRT in most of these drugs. I choose you for your critical care fellowship. So what do you think?
Probably true.
So you want to dissect this question more. So molecular weight is the main factor for drug removal by CRRT. So number one, you want to know what's the molecular weight of most of the drug that we use. What's the molecular weight of most of the drug that we use? Is it too big? Is it small when you compare it to potassium, sodium?
It's big.
It is big, but it's not as big as you would imagine. It's actually still within the small molecules, below 1,500. So most of those drugs actually below 1,500. There are very, very small number of drugs that are really, really bad and big. So if you think about molecular weight of the drugs, most of them, they can be, as far as replacement therapy, they can be removed if you look at the molecular weight. So in terms of molecular weight, removal by CRT, it can remove any drug because those molecular weights are small. Does that make sense?
Yeah, that does. So this would be a false statement then.
Correct. That's your answer.
Yeah.
It's a false statement. Next one. Let's do Charzad. Fluconazole needs higher doses than used in normal renal function. What do you think?
not sure. I can't
So
imagine
let
why
me
it would be.
let me give you this. So when you think about CRT, what kidneys do that CRT doesn't when it comes to drug filtration, secretion, reabsorption?
Secretion, I guess.
Yes, secretion, reabsorption, CRT doesn't do it. So when you have CRT, you just filter drugs. And you waste it, isn't it? You do not reabsorb as the kidneys does. You do not secrete drugs. So any drug that actually gets reabsorbed, like fluconazole, when you give the same dosage, what's going to happen? It's going to be subtherapeutic. It's going to be subtherapeutic because you're not giving enough, because you're not giving that reabsorption from the kidneys. If you give a medication that's secreted, then you will be actually harming the patient because you're giving supratherapeutic dose. So that's something that we should look at when you give those medications. Is there a different thing that the kidneys does with those medications that the CRT doesn't do? Make sense? Okay. Next one. Who we have? Adamus. What do you think? Drugs is likely to be removed by CRT if it's more than 90% protein bound.
I got the easy one.
You get the first of this and the next one. Let's do it too.
So this is false. So the more protein bound, the less that the drug is going to be removed by CRT.
And that's the most important when it comes to drugs bound, isn't it? That's the most important when it comes to drugs removal, is protein bound. Okay, next one.
Me again? Okay,
Yes.
so CVHDF is better than CVH in myoglobin removal. So yeah, so myoglobin is a big molecule, so you need convection for that. So CVHDF should be better.
Correct, and it doesn't change the outcome, but it's better. Okay, next one. Good job. Okay, Russia. Effluent volume is the most important renal replacement therapy related factor affecting drug removal. What do you think, Russia? Russia is not listening to us, maybe. Okay. Russia?
Yeah, I'm not sure
Okay,
where she
that's
is.
fine. That's fine.
It might not be on, yeah.
Okay, Carson then.
All right, so yeah, I would have to go with yeah, I mean, I would go with I think the most important thing is the rate. So I'm not sure if the volume is the most important.
Yeah, that's the volume rate. That's the rate of the volume, effluent volume. So that's your rate and the duration.
Yes. That is, I think, true.
That's true, completely true. That's what we said. Is a clearance is equals actually to fluid, effluent fluid. Next one, Zain, is drug level will be more likely to be subtherapeutic using CVH with pre-filter fluid replacement than using CVHD. What's your thought, Zain?
I think maybe false.
So what's different about pre-filter fluid replacement when we add pre-filter?
What's different is that it's mixing with the blood, obviously, before the filter.
Okay, so
that then the blood is not necessarily as concentrated going through.
Okay, then
I'm thinking along the lines of.
So that will make less drug reach to the filter and less drug filtered, isn't it?
Yeah, that's why I said false, because I thought maybe the drug level will be. Oh, that would be true. I see what you mean. Yeah, will be more likely to be subtherapeutic.
Yes. So will it be more like subtherapeutic or supratherapeutic? Because you're removing less drug.
So it'd be super therapeutic.
Correct. So it's going to be wrong because you have less drug that getting to the filter to clear down. So you have more drugs. You have less clearance. When you have more pre-filter fluid, you have less clearance. Make sense? Right. Okay. Next one. So, and this is you guys seen before. If you look on the left side, diffusive, your beta-2 microglobulin, which is the lower curve, it's not as effective when it comes diffusive, when it comes to that removal of beta-2. When you compare it to the right with the convective, it's better in removal of beta-2 microglobulin. But if you look at the small molecules, it's almost identical. Okay. So let's do this one. It's going to be with Russia.
You hear me now?
Yes. Oh, yeah, good. So this is one of the patients that you do every day. We want to calculate the dose and creatinine clearance. So your dose, you have 2 liters, and you have 100 ml, 100 kilograms, and you have ultrafiltration of 200. So what's your dose?
Let's see. Okay. So it's going to be 2,200 ml per hour.
Yeah, so 2,200.
Effluent, yeah.
Yeah, that's your effluent, and you're going to divide that by 100 kilograms. So it takes the 2 zeros away, so it's 22 ml per kilogram. What's your creatinine clearance? Do you know how to measure that?
Yes, but I don't remember the
So
equation.
it's the same. So it's the same thing. It's very simple. It's the same thing. It's like your urea clearance. It's like any small molecule clearance, which is the same effluent rate, which is 2,200. And instead of ml per hour, you divide that ml per hour / you make it in minutes. So you divide the 2,200, you divide that by 60, that gives you 36 ml per minute. Okay.
Okay.
Next one. So that gives you that. So this is actually your Russia. You remember I asked this question last time. So this is your patient. You have Russia still. You're gonna finish this one. 100 kilos. The same sitting, but we have dialysate 2 liters, but no ultrafiltration. What's your potassium clearance per hour, assuming the serum K level is constant at 7, using 0 K dialysate? So we have the answer there. So this is the way you think about it. You have 7 milliequivalent of potassium. Okay, we said there's saturation, and the sieving coefficient is 1, meaning whatever is in the blood is going to be in your effluent fluid. So if you have 7 liters, if you have 7 milliequivalent of potassium in the blood, how much they're going to be in your effluent fluid? They're going to be 7. So with every liter that you do, you're going to be removing 7 milliequivalent. So if you're doing 2 liters, you're going to be removing 2 times 7, because you have 0 K there. So it's going to be 14. Okay. But if you use the 2 K dialysate, then the difference between your 2 K fluid, okay, a dialysate or replacement fluid, whatever you're using, if you're using that, then you're going to be having the difference between 2 and 7, which is 5. So if you do 2 K and you do 4 liters, then with every liter we said you're going to remove 5, because you have already 2 in your fluid, and the difference between 2 and 7 is 5. So if you multiply 5 by the 4 liters that you do an hour, you're going to be removing 20 milliequivalent of potassium. It cannot tell you, as I said last time, it cannot tell you if this is going to be enough or not. It depends on your catabolic state of the patient. But with higher, as we know, with higher effluent, you're going to be removing more potassium. Okay, next one.
I just ask on that note, so in reality, it's actually less than what you're calculating, because over time, your potassium concentration is reducing, correct?
Correct. So that's why if you see in the STEM question, assuming everything is constant, humans are not constant, as you said. There will be a difference between your reservoir of the potassium and fluxing that potassium from intercellular muscles and all that to intravasculars. But just to think about it this way, it makes it easier. Okay. Does that make sense?
Thank you.
You're welcome. So let's do this. You pick this one. Shahrazad, you pick this one. Let's do this one.
Okay. So
you have 100 kilos, 30 hematocrit, blood flow is 100. Your replacement is pre-filtered 2 liters. Is this dose appropriate? What do you think? We calculate the dose there. It's 2 liters divided by 100, 20. What do you think? 20 ml per kg per hour.
Is the dose appropriate, like for the
Yes.
patient?
Yes.
The CRRT dose? It's a little low.
A little on the low side. Why?
Like 25 is, I guess, what I've been aiming. But
Yes. So today, Cardigo says 20 to 25, but to achieve that, you actually want 25 to 30. So that's number one. So you need 25 to 30 to achieve actually what you prescribe is not what does get delivered. So you have to aim higher to be able to achieve your 20 to 25. So that's number one. But there's another factor called dilution factor. We're using pre-filter here, isn't it? So that has a dilution effect. This next slide, please. So your dilution effect, it's the effect of your pre-filter fluid to the concentration of your water plasma. So it's your plasma water divided plasma water plus your pre-filter fluid. So if you have a patient that you're running 100 blood flow rate, so 100 times 60 minutes, 6,000, and you multiply that by 1 minus your hematocrit and divide it by the same thing and add your pre-filter. So that gives you 0.7. So you actually not giving, as we saw earlier, 20. If you multiply the 2 liters by 0.7, you're actually giving 14. What's that? 1,400 ml per hour. So that's how low you're giving. That's how much. And if you divide that by 100 kilograms, that gives you a 14 ml per kilogram. So this patient is getting only 14 ml per kilogram instead of what we thought, which is 20. So when we add pre-filter, the good things about pre-filter lowers hemo concentration, but the bad or the thing that you want to be careful with is your dose going to be down. And also your clearance will be down. As we talked about earlier, when we talked about drug clearance, your drug clearance will be down, your solute clearance will be down. So if this patient, if critical care team call you in a couple of hours and tell you that the potassium is going up, your acidosis is going back, because your dose and clearance is down. You see the clearance difference here and the dose difference. Okay, next one, please. So this is, as you guys know, dose prescribed, dose delivered, way difference. A lot of, we prescribe between 20 to 35, most of what's delivered below 20. Next, please. So, and you guys, we talked about this ATN trial and a renal trial, and there was no difference between the intense and less intense group. Next, please. And the dose dependent we talked about last time. Next, please. So let's look at this one. And Hadamus, go for this one.
Okay, so 55-year-old male admitted pneumonia complicated by septic shock and uric AI, ischemic hepatitis, thrombocytopenia, severe lactic acidosis, lactate and liver enzymes straighten up. Patient starts CVVH. In the middle of the night, is nurse calling for recurrent circuit failure. 3 so far. Weight is 100, hematocrit 30, blood flow 100, UF 0, post filter 2000.
And she's a smart nurse. She sent you a text with from Prismaflex, and these are the numbers you got.
Okay.
What do you think is going on? What do you think of what do you think of the prescription that Qasim put in and got to sleep, and they calling you at night now?
Yeah, so he's on 20 mLs per kilo. Should be around 25 mLs per kilo. So maybe we could go up a little bit on this.
But they're not concerned about clearance. They have no concern. They didn't calling for hyperkalemia, acidemia. They're concerned about circuit failure.
Yeah. So
Look
if
at the
this
numbers down.
clotting, yeah. So high filter pressure. So probably the patient is clotting the filter, and the reason why is because it's going post filter. So you're hyper concentrating the blood that is going through the filter. So you can put it pre-filter, and then you're gonna have less clotting at the expense of some decrease in clearance.
Yeah, good, very good. Let's look at those numbers. Let's go next slide, please. So these are the pressure monitoring system that we have. This is pressure flex. You have the axis pressure negative, 50 to 150. If you get positive axis pressure, that's very alarming. You have to think about that you're not putting the line in the right place. So positive axis pressure, negative axis pressure should be before the pump. After the pump, you start having positive pressures. So you get your filter pressure up to 250. Then you get the effluent pressure coming after, and the software will calculate for you the transmembrane pressure and the pressure drop. We'll talk about those. And you have your return pressure, which is positive 50 to 150. Next, please.
Sorry, Dr. Yoosif, I had a question. Could you also like increase the blood flow to help with the pressures?
Yeah, so we're gonna come back to how can we fix this one. Let's look at the pressures first, and we'll come to that, Qasim. So this is the filter pressure drop, which is the machine will calculate it for you, but you can see it there. It's a drop in the pressure that occurs when the blood flow goes down, and that's because of clotting inside the whole fibers. So if you have small clots that are accumulating, and these clots are making the flow slower and slower. So you start with higher pressure, and you end up with the lower pressure toward your axis, when you're going downward your return. So your filter pressure will be very high, will be in the above 250, and your return pressure will be lower on the lower side, and the difference will be your pressure drop. So that is clotting. So this is the clotting that happening within the hollow fibers. Next one, please. So that is different from your transmembrane pressure, which is, it reflects the pressure across the membrane, meaning between your fluid membrane and your blood. So this happens because you have proteins that clog those holes, and that makes the pressure higher. Next one, please. So this is clotting and clogging. So with clotting, you have higher pressure drops, as we said. The hollow itself is clogged. It's clotted. So you have higher pressure, higher filter pressure, and pressure drops. In the clogging side, because as we said, protein coating those small permeable holes, the filter pressure will be high, the same thing. Transmembrane pressure, which, as we said, it calculated the pressure at the membrane between your blood and your fluid. Also, you have higher negative effluent pressure. Next one, please. So let's look at this one. This is the same patient, 100 kilos, blood flow rate 100, UF is 0, post filter 2000. Your axis pressure is normal. Your filter pressure is high. Your transmembrane pressure is normal. Your pressure drop is high. So this is classic clotting. Okay, so what to do for clotting? Qasim, you go for this. You're thinking about ideas. These are the options. We'll come to your options, but this is, so which option you want to go for?
So I mean, citrate is a good option. That would because it seems like the issue is clotting, so you can do citrate, or
I can refer you. When you say citrate, what you have to make sure that the patient doesn't have, which this patient already have.
Hypocalcemia.
Hypocalcemia is fixable, so you can, and you will have hypocalcemia, but I'm talking about when not to start citrate. So as we said earlier, if you have lactic acidosis, that's getting worse. Some people will throw the number 8, but if you have severe lactic acidosis, shock state, that's getting worse. If you have liver malfunction, meaning that shocked liver, that the LFT is going skyrocketing and not getting better, then your citrate will not get converted to bicarb, and there's no point in doing citrate. So it's contraindicated in those. So in this patient with lactate going high and LFT is going high, it's not the place where you're going to use citrate. So that not for him. So what else?
So you can adjust the prescription.
You're not just a prescription. So this is not a catheter issue. Not going to keep you in the catheter. You're not going to keep changing the filters. Okay, next one, please. So this is what we call filtration fraction. It's the ratio of your fluid that you remove across the filter to the rate of fluid entering the filter. So if you have more fluid that's crossing your filter, then you'll have higher filtration fraction. And that will make your concentration go higher, and that will make your protein accumulate and coat that membrane. Next, please. So this is our patient. So what's the filtration fraction for this patient? If you take so the post filter is 2,500, and you divide that by your plasma flow, which we said the blood flow is 100, okay, and multiply that by minutes 60 and multiply by 1 minus your hematocrit rate, it'll give you 59%. So it's very high. So this prescription is meant to clot right away. So Heidemann said, let's do this pre-filter. We did that here. If you do a pre-filter, 2,500, still use 6,000, and you added 2,500. That brings your filtration fraction down to 37. So it's good, but it's not where we like it to be. Then Qasim said, let's increase your blood flow. And that did the trick. So all these do the tricks, but every one, it does it in some percentage. So if we increase the blood flow to 200, then the filtration fraction will come down to 23%. But don't forget, whenever we make the changes, when we put pre-filter, that dilution factor has to be applied, and your dose will be lower. So here the dose will be 19. Next one, please.
So, Dr. Yoosif, I had a question about the pre-filter. So it seems like pre-filter and post. So if you're using 25, so if the dialysate is 2,500 pre-filter, and so it's also going to be 2,500 post-filter, but you're going to use that as a division factor as well.
So only you added pre-filter. It's only you added as pre-filter, okay? When you on your denominator, we can go back to the previous slide. So if you see in the first filtration fraction with the post filter, we did not add the 2,500 as denominator. It's only nominator. But if you add it as a pre-filter, okay, so that's your fluid that entering. So the down is, as we said, the filtration fraction is the fluid that crossing divided by the fluid that entering to your filter. So the pre-filter only one that goes in there. Make sense, Qasim?
Got it. So it's the same dialysate, but we're doing it before the filter.
It's the replacement fluid. If we want to be terminology more correct, it's dialysate, you're going to use for dialysate. So it's, yes, pre-filter fluid. It's a replacement fluid dialysate. So you're going to use it pre-filter. Does it make sense?
Got it. And that replacement fluid could be anything, right? It could be like normal saline. Is that what we're talking about here? Or?
Yeah. You choose based on your needs. Right?
Okay.
It can be your normal. Can be if you have someone who has hypernatremia and you want to use D5. If someone has hyponatremia, you want to use D5. It can be based on what you like. It can be citrate. It can be anything that
Got it.
you add. Okay. Very good. Next
Got it.
one.
Okay.
I just ask one quick question as well.
Yes.
How do you define when you're writing the actual prescription pre-filter versus post-filter? Just as a practical point of, I don't know, because when we order it, there's like two options in terms of where you put the fluid. Does anyone know like how you define that? Because the automatic, my assumption has been that it's always pre when you write replacement fluid. Is that correct?
So you want to look at those. So I mean, you can have generic one where you have like pre-filter 1 liter and post-filter 1 liter, or pre-filter 1500 and post-filter 500. But I think you have to take and it's going to work most of the time. So, but we'll come to those factors. So that's what we're talking about, those factors. When you have higher prescription, then problems will start rising. But if you have small prescription, whatever you do most of the time will work, as long as you not putting all post-filter, because you're going to generate high filtration fraction. Okay, so the more post-filter, the higher your filtration fraction is going to be. The more pre-filter, the lower your clearance will be. So you wanna balance that out. Okay, and let's look at those, and we'll be more clear.
Yeah, I think what Shahraz is trying to ask is just when we order the CRRT orders, whether it's CVVHD or CVVH, it's usually we only have an option to order the therapy fluid rate, and that's it. So we don't have any specification in the order set.
Okay, because Ziad, do you know? This is Ziad Hanimus. That applies in GW. That doesn't apply.
Yeah, it's just in the in our hospital.
They never apply in the VA. VA, you should have those.
Okay, understood. So it's okay. That's why I was just trying to figure out.
So yeah, but why? Your question is right then. Why? Hadimus or Zaid?
What was the specific question? Why what?
Why they don't have the options of ordering pre and post filters in here GW and the LC?
Because we can only do CVVH and CVVHD, right?
Correct. Yeah. So you have mixed stage here. You have 3 pumps, one for Effluent, one for your dialysate, okay? So and one for your blood with mixed stage. If you have Prismaflex, you can do whatever you like. So your next stage, you're kind of limited there in choosing what modalities wise. Make sense?
Yeah, that makes sense. That's why I was confused why we couldn't order all these things. Okay, that makes sense.
Yes. So you have only three amounts.
So this is Susie. So if you want to do a post filter, you just write a nursing note and say no pre-filter replacement fluid, and just put all the replacement fluid in the post filter. You just have to write it out. It's doable.
So I don't have a lot of experience with next stage, but my understanding, next stage you have only 3 pumps. So there's a pump for the blood, there's a pump for your dialysate, and there's, or whatever you want to call it, and there's a pump for the.
Oh, I see. So there's no pump. So
there's no pump.
Just put like an IV fluid and
yes, you can do that. Yes.
Just like a fluid replacement, and
correct.
You put it post-filter. Or
that
you can
works.
even just put it peripherally. It doesn't matter because
correct.
it gets mixed up.
Correct. But as far as the pumps itself, you don't have that capability for next stage.
Yes. Okay.
Very good. Okay. So let's go and Russia. I'm going to pick this one. Let's go one at a time. So all the following would reduce filtration fraction except increase blood flow rate from 100 to 200. What do you think, Russia? Would that decrease your filtration fraction?
Yeah, based on what we just discussed.
Yes, that's what we witnessed right now, isn't it? We pumped it. How about decreasing your UF rate? So UF goes in the numerator or in the denominator?
Denominator.
No, it goes in the
Oh,
your numerator is all the fluid that crossed. The UF, this is the fluid that crossed your filter. So if you increase those fluid, your filtration fraction is going to go up. If you decrease this fluid, your filtration fraction will go down. How about the next one? Decrease the post-filter replacement fluid rate. If you decrease it,
it's going to go up.
So if you decrease it, your filtration fraction is gonna go down, isn't it? Because you're gonna decrease the amount of fluid that crossed the membrane because you decrease the post-filter fluid. So whatever you want to order post-filter, that's gonna be coming through. This is gonna be fluid crossing the filter. So if you decrease it, you're gonna decrease your filtration fraction. How about adding pre-filter replacement fluid? Would that reduce your filtration fraction?
Yeah, it will.
Correct. That's but always, as I said, dilution factor. How about increasing the total replacement fluid to 3 liters? If you increase your fluid replacement, then a lot of fluid is going to cross. There will be a lot of filtration.
Fraction, yeah, it's going to go up.
Especially, yeah. So when you go above 2 liters, this is to Shahrazad. When you go to higher, the higher your fluid replacement, the higher your filtration fraction. So when you get to people that are very big with higher BMI, you have to have diffusive clearance with the convective clearance to keep your filtration fraction down. You cannot get away with only hemofiltration because you will get to the problems of high filtration fractions. So if you get to 3, it's actually above 2, you start noticing that the filtration fraction will go up. This one randomized controlled trial, they increased the flow rate from 150 to 250 blood flow. It didn't make a difference in circuit failure. So increasing the flow rate above 150, it didn't change in circuit failure. Next one, please. So this is another patient, as you see here. Problems here, we have filter pressure at 300 and the P pressure drop 250. So it looks like it's a clotting problem. So Qasim, what we said we're gonna do, keep changing the filter. We said no, increase the pre-filter fluid.
Yep. So I think this is a clogging issue, not a clotting issue, right?
It's clotting. Clogging, you have transmembrane.
Oh, yes, TMP is 100. Yeah, so that's less than 150. Yeah,
but
so
if
this
you
is
look,
once again.
yeah, but if you look at the stem here, they tell you that the lactate is getting better and the LFT is coming down.
Yeah. So now what I would do is, so the blood pressure, the blood flow in this stem is
200.
200. So there's no difference between 150 to 250 according to the previous study you told us. And the fact that everything's improving, maybe citrate may be the best option.
Yeah. So that I will go for citrate. Absolutely. Yes. Next, please. So this is the citrate, as you guys know, 3 bicarb. You need liver for that to happen. It happens also some in skeletal muscle and kidneys. Next, please. Okay, so it chelates your calcium. So intrinsic pathway knockdown chelates your calcium. Next one, please. So you always want to look at this diagram when you think about ionized calcium, protein bound, and calcium citrate. The complex calcium, the total calcium will be on the higher side when you have citrate toxicity because it's not going to be abnormal. It's not going to be low. What's going to be low is your ionized calcium. So calcium citrate plus the protein plus ionized calcium is going to be on the higher side. Your ionized calcium is going to be on the lower side. Next one, please. So this is the way we run the citrate pre-filter, and we'll actually have we'll work on finding out. I'm going to be looking to the barrier of us not using citrate. So I think we should be able to use it if we can find out the barriers and work on them. But it's sometimes the people think hesitancy to start the citrate is actually, it's bigger than the real challenge itself. When you start, it's way easier. So next one. When it comes to citrate, it's clear. We have randomized controlled trials that has showed a reduced risk of citrate, of circuit loss, and incidence of filter failure when you compare to regional and systemic heparin. It's lower bleeding than the systemic heparin. Next one, please. No survival benefit in all the trials. So, okay, so this is a randomized controlled trial that was published last year in JAMA, and it's, if you see on the right side, there's a big separation, nice separation between regional citrate and systemic heparin anticoagulation when it comes to circuit survival. There's no difference in terms of mortality. Next, please. So citrate toxicity is going to be in your exam. So this is going to be in your exam 100%. So risks in that: liver failure, shocked liver, shocked state, lactic acidosis. Basically, you're not clearing, you're not getting benefit of your citrate. So the diagnosis, you're going to have worsening metabolic acidosis. Your calcium infusion is going to be going up. The nurse will be calling you every other hour, asking you to increase the calcium infusion. And she's going to tell you, I'm following the protocol, and the calcium requirements going up. Your ionized calcium is going down, and your total calcium increasing. If you calculate the ratio, it's going to be above 2.5, your total calcium to ionized calcium ratio. Next, please. So the advantages and disadvantages we talked about: better circuit, better less clotting, and no benefit as far as survival when it comes to citrate. Next one. So this is the clogging. So we talked about when you have high transmembrane pressure, that protein, when you have a lot of filtration, when you're doing convective clearance, you have high transmembrane pressure, you have high filter pressure, and high negative effluent pressure. What are you going to do for this Hyponatremia? All the following may reduce the clogging, except Hyponatremia.
Yeah, I'm thinking.
So let's think about together. We can think about, so you have clogging, okay? What are you going to do? So the clogging happens with what modality more?
It happens with the
sounds like convective, isn't it? You pushing more stuff through the filters, so more protein. So if you have convective, so if you switch from CVH to CVH-DF, is it going to make a difference?
Maybe it will help a little, but I guess switching to CVH.
It's gonna, so anything can help. So there will be less burden on the filter. So if you use dialysis, diffusion, it will be so. Switching to CVH-DF may help. Okay, switching to CVH-D at all, filter, avoiding the hemofiltration, avoiding the convective, then it's going to be helpful as well. How about citrate for anticoagulation?
No, that will not help.
It's actually, it does help. It helps as well. It's been found that it helps as well. How about increasing your replacement fluid, increasing your pre-filter, and increasing your post-filter?
Let me think.
That will make more fluid go through the filter.
So that will make it worse.
Will make it worse. Yeah. So everything is going to make it better, but this one, increase your replacement fluid, is going to make it worse. Next, please. Good job. So let's look at this one. So this is going to go for your Russian. Critical care fellow exchanged the IJ catheter as it wasn't working. He sends you a screenshots before and after the change. We just wanted to confirm with you if things are looking okay. Russia, you hear me? Okay.
Yes, I can hear you.
Okay. So let's first have the first half of the question. Is it legitimate change of is the problem with the catheter here, looking at the left side? Axis pressure. Yeah, so the axis pressure is very, very negative. So that catheter, either we have problem with some fibrin, clogging that catheter. We have it against the wall, or the catheter pushing it, something making that access pressure negative. And the ICU fellow tried everything, it didn't work. So he ended up changing it. And this is what he got after. And the nurse didn't feel good about it. So he sent you this. What do you think? So access pressure is positive.
It's
25. Forget about all the other numbers. All the other numbers looks
still
normal.
low.
No, but it's not negative. It's
not
positive.
negative. Yeah, that's the.
Okay.
So there is resistance.
So there's a positive pressure coming out of. So the negative is happening because you have a vein that you're sucking from it, blood. But it sounds like there's something pushing blood up. And he said there's an X-ray, but he's very good at doing procedures. Like Zaid, let's look at the X-ray.
It doesn't look like a venous.
Yeah, this next slide.
Access. Oh, it's not in the right.
It's in the carotid.
Yeah.
So
that's why it's high pressure.
That's why it's positive pressure, isn't it? Mm-hmm. So he put it in the fistula, but not the right one. So when you have positive pressure, you have to be very careful where that pressure coming from. Okay, next one, please. So Ecmo, there were multiple ways of putting Ecmo with CRT. In fact, now with COVID, we do not do it. Everyone has the access, Ecmo's access. We have our CRT access with the clotting problems with COVID. But this is not a COVID patient, it's a CU exam. So this is influenza patient put in Ecmo. Where do you put the return limb? Meaning, so the blood went to the CRT, cleared, and you want to put back the blood. Where do you put it? Do you put it before the oxygenator, after the oxygenator? Doesn't matter. Or you need a central line, different central lines. I
believe after the oxygenator.
So why after, not before? So what's your concern? In any circle that you connect to human body, air, isn't it? So if you have concern with air, you want to put it before the oxygenator where you can catch it, clean it, make sure nothing is going through, or you put it after?
Well, I see what you're asking. So it's saying the CRT return limb, a blood flow from the CRT machine to the patient should be placed. So it should be proximal to the oxygenator, I guess.
Proximal, yes. So you can. So your access limb can be anywhere. You can take it from after the oxygenator, before the oxygen, whatever. There are multiple ways of doing it. Okay, but your return has to be before the oxygenator. It's just a double safety there. Make sense? It's got to be in your board as well. Next one.
So I just want to clarify. You can do the access limb after the oxygenator, but retain it before the oxygenator. That's something you can do.
So the most important, there are multiple ways of doing it. Some people will take it after oxygenator and return it before. Some people will take it before and return it before. The most important is where you return the blood, which is you have to return as a safety. You have to return it before the oxygenator. So in case there's some air, some leak, then you have the oxygenator is going to catch up that and make sure it doesn't go through. So that's the most important. Make sense? Okay, so hyponatremia. Yes.
Sorry, I have a question. For the machine itself, doesn't have like a filter to trap like extra air or like air bubble.
It does, but it's you see those Ecmo lines, they're very big. So you just want to have to be more cautious and more careful. So that's what we do it for.
Okay.
Yes. Hyponatremia. So how you manage hyponatremia CRT? There are two ways of doing it. Either you put a sterile water in your fluid bag, or you calculate it. You calculate how much D5W, and you use those D5W as pre-filter. Or Dr. Lou said, you can run it on the side. Doesn't matter, both works. So it's the same way when you calculate your need for D5W. Your dialysate sodium minus your goal sodium divided by your dial sodium, and you multiply all that by your therapy fluid. Next, please. So this is the same thing. So 140, you start with, for example, 120, and so you need 285 ml per hour. So very simple. It's like when you calculate how much D5 water you need, but you consider your sodium is, you're going to consider the sodium 140, which is your dialysate sodium, what renal fluid replacement sodium content, 136, 140, whatever the content there, you're going to put it there, and you're going to have your goal sodium, and that will give you how much free water D5W you're going to get. Or next one, please. You can add free water. You can 5 feet replacement fluid if you get next stage. This is the amount of volume on the left, how much you put, and this is how much sodium it becomes as far as concentration. But be mindful of the other electrolytes as well. Your potassium go down, bicarbonate, calcium. So you have to be mindful of this, and sometimes some institution doesn't allow it because sterility issues and error issues. So there might be a problem with this. But if you were to do it, this is how you do it. Next one, please. That's it. Questions?
Yeah, just for the hyponatremia, is the calculation similar?
Yeah, so there's a calculation. It's the same way. It's the same way you calculate it for your using 3% or 2%. Yeah, there's a calculation for that as well. Yes.
Okay.
So after we do those calculations, do we have to subtract the amount of fluid that we're going to use from the effluent fluid or the dialysate? Because I know that with the Prismaflex, usually you can actually control the fraction of the liter, but when it comes to next stage, it's like it's really fixed, like 2.1, and usually it's like 200 cc or something from the dialysate. So it's really hard to make that adjustment.
Yes,
it's like less than 100.
Yeah, so you have to be careful. So as Shahrazad said in the beginning, this is a physiological thing. These are not absolute numbers. Even when you adjust those numbers, there will be changes when it comes to fluid, when it comes to patient getting out of fluid somewhere else, patient perspiration, if patient's having diarrhea. So this is not absolute number that's going to be exactly. So when you have someone who's having severe hyponatremia and you start your prescription, you want to aim toward lower prescription, not to be aggressive, and you want to follow it very religiously at the beginning, more often, and then as you feel confident it's working well, then you cut down your frequency. But yeah, those calculations deal with the body as a flask. It's like you dealing in the lab with a flask where there's nothing else that's going on. No, there are other factors. So you have to be very mindful of that.
Okay, thank you.
You're welcome.
Thank you.
Thank you, guys. If there's no question, then we'll have a good night, everyone. Good evening.
Thank you, Dr. Abdalla.
Thank you. Thank you.
Thanks, Doc.